Thank you again. So Rosen gave me this title, and when you talk now and when you think about the paradigm shift we heard in the two lectures going from laparoscopic to what is possible also in robotic, and I have to say that we start in rectal cancer the last 40 years, going through the milestones, beginning where Bill healed at his holy plane and going up to the TNT here to the total neoadjuvant chemotherapy. And I want to tell you, not to be too long, I lost some time now here, but to share with you the time as time goes by and the paradigm shift of the rectal cancer treatment. However, you know these guys, Bill Heald was very often, traveled very much, showing his holy plane, and nobody believed him at that time. Nobody said, it can't be a recurrence rate of 3%. And by the way, I have to say that now in May, he's celebrating his birthday. And I have the honor to chair this session together with Antonio Lacey. And he's really a living legend, and he will visit us also at the EFR conference in September, to whom I would like to invite you, all of you. This is a man from Germany, Stelzner. He was the only guy, only professor, having 3 universities, and his whole life, he spent his whole life with the involvement and the surroundings of the rectum anatomically. So, and we did a step further on in this publication. You can see we published the intersphincteric resection with great success, going in the intersphincteric space, and did this resection with a protective ileostomy. But what about radiation therapy? And do you remember Papillon? And sometimes people forgetting Papillon was the first time in small tumors, the rather high cases. He treated the small rectal cancers by radiation therapy. And this project was done further on by Norman Nigro, treating the anal cancers with the same protocol, but giving fewer chemotherapy. And Arthur's son, he remembered the Papillon treatment, and now in the UK at the Klettering Center, he's treating with radiation therapy the small rectal cancers, again with great success. So, going now to the guidelines of the ESMO guidelines, the clinical practice guidelines, what is today? You have an MTD with experts. You go to the full medical history, but you should go back to the relatives, to father and grandmother, because we believe, and now we have here some hits, that the genetic plays a wide and great role. Physical examination, of course, and of course the serum CA level. Perhaps in the postoperative, in the follow-up, it's more important, doing of course the colonoscopy. The ultrasound is only for small tumors, recommendable, but MRI is mandatory in the workup. And to differentiate between high risk and low risk criteria, I come to that later on, and of course, before the operation, the CT of chest and abdomen. So, when you go now to looking at the differentiation and comparison of the laparoscopic versus rectal versus the robotic, you can see, and the open, that there is no statistical significance between them all. So, and if you look at the open laparoscopic and the robotic, that there is no sexual and anorectal dysfunction or differentiation as well as in the quality of life, and also in the various TME techniques. So we have to show with all kinds of from organ-saving surgery have shown oncologically safety nowadays, and this is very important. However, I have to state that when I was in Champaligo with Amjad Parvez, that the more, as we heard from Tilo Hacker, the first lecture, the more you do, the more experience you have. And I think in the future, the robotic, as Amjad pointed out, will be over the laparoscopic surgery. Let's say in 5 years, I do think that the robotic surgery will overcome the laparoscopical procedures. Another milestone in Germany, the German study showed that the preoperative radiation therapy, the chemotherapy, is better than the postoperative. At that time in America, they stated that the postoperative chemotherapy should be done. But this German study showed that in terms of relapse toxicity and chronic toxicity is over the postoperative. I see a Polish colleague here, and I always mention here Krzysztof Wójko. He compared in this Polish study the short course with the long course. And in that time, we have seen, and that was so thinking to the watch and wait, that the chemoradiation showed a complete response rate in 16%, but about that a little bit later. Lars Parman, he died too early, but in 12, 13 years before, he recognized the priority of the radiotherapy and radiochemotherapy. And these 4 questions should be very important, should be also a milestone for the next years. Should the radiotherapy given before or after surgery? That was answered now with the SAWA study. Should it be long course or short course? Should long course given alone, or should we give it chemotherapy? And what's about sphincter saving? Should it we do with preoperative, postoperative, or it's a must every rectal cancer to save the sphincters? Is it important to get a pathological complete response when we operate? Yes, it is. In this study, we compared the 5-year survival of patients with pathological complete response with no pathological complete response, and it was so that it achieved a better 5-year survival, a better 5-year distal metastasis-free survival, and also in the long term a better life of quality. And it was a milestone and also a paradigm shift. As Angelita Habergamer showed us that the neoadjuvant chemoradiation therapy led to a complete remission in nearly 30%. And I remember the first conferences in Paris and others in Germany and also in Vienna, we discussed a lot. And a very famous surgeon at that time said, no, there is no place for chemoradiation. We are surgeons. We have to resect the rectum. So, but it's not true. He is still the boss of a very important institution, so I won't tell his name now. So, and you can see that also Habergamer showed it in small tumors, that after 16 to 18 weeks, you have a complete remission. And people did not believe her and said, yes, it's a patient selection. But however, you see, it's 7 years ago. But what's about oncology? What about the outcomes of this watch and wait? Now, you see, you have a local regrowth. That's not a recurrence in 22 or even more percent, 22, 1/5. but they occur in the first 3 years. And salvage surgery is possible nearly in 90%. So the conclusion is, following neoadjuvant chemotherapy, a watch and wait procedure appears feasible and safe. And when you see here, we have data now in the watch and wait database, more than 2,000 patients, and we can conclude that it's really, but however, really in this, what I'm telling you about the life quality and so on, the sphincter sparing procedures, but bear in mind the local regrowth rate. Nuno Figueiredo from Portugal and Gerard Beetz published this paper saying that yes, we have about worldwide till 30% local regrowth, as I told you, but 84% of them, 84 patients, nearly 95% underwent surgery. And after 2 years, there is a local regrowth-free rate, nearly 100%. Distant metastasis, 91%. And the disease-free survival and overall survival was also very satisfactory. So they underwent a treatment with curative intent. But if you look further on the oncological outcomes for low and intermediate rectal cancer, then you will see there is no difference when you compare these figures in overall survival and 5-year disease survival between two groups, watch and wait, and if you do the operation first. So that there is no increase in local recurrence, but in local regrowth rate, you have in watch and wait a higher number to expect. But your life quality is better, you do not have a stoma. It is superior in preserving the organ integrity. But however, you can go to organ preservation and perhaps by ileostomy, and I come to that later, to the stoma problems. But however, watch and wait is an alternative to surgery. Are there risks? Yes, there are risks. As I told you, the local regrowth rate after watch and wait, and when you look at the near complete pathological response rate comparing the patients managed by the TME, the disease-free survival, looking at the 3 years data comparing watch and wait to TME, and in the local recurrence rate compared with the near pathological complete response is higher than in the near pathological. So the radiation therapy brings us a higher local regrowth rate, and also in the 3-year disease free survival for patients is higher than in the operation group. So the conclusion is the local regrowth appears to have a higher risk of subsequent distal metastasis in the group of the watch and wait. So what about the lymph nodes? It's a very important issue if you have rectal cancer with nodal regrowth. We call it now nodal regrowth. Again, Gerard Beetz stated this. A very small number, he detected large lymph nodes, and 35 of them, 17 had immediate therapy and irradiation before surgery, and 18 were diagnosed, have gotten a PET biopsy or an MRI with combination. 33 patients underwent TME surgery, and look at this. In 27 patients out of 33, there were positive lymph nodes, and 5 of the other 6 had luminal lymph regrowth. That means you must not have a luminal regrowth, but you can have a nodal regrowth. So the conclusion is you have to do a magnetic resonance imaging. It plays an important role in the diagnosis, and the repeated magnetic resonance after an interval can be helpful in making the treatment and this decision. But however, a CT and endorectal ultrasound guided biopsy, these procedures seem to be unlimited, limited. So there are pictures, images from my experience here before radiochemotherapy and after. It's only a scar here. And look here, we have a lymph node preoperatively which did not disappear after neoadjuvant chemotherapy, although there is no tumor. So the tumor board, the MTD said we had to go to the operation, and really the lymph node was positive. That's a very, very interesting study in the BGS, just 1.5 years before. Brandon Moran was responsible for this. He compared low risk, moderate, and high risk patients. Low risk means the extramural vascular invasion was negative, tumor deposits negative, the CRM was clear. In the moderate, there was the invasive was positive, also the tumor positive, but the CRM was clear. But the most negative impact is the circumferential resection margin. And if you see in terms of the overall survival and disease survival, of course the low risk do better in both sides. This is a patient we treated 2013. I have seen her in February after neoadjuvant chemotherapy, deep rectal cancer, still a scar here. The patient, the lady, is doing well. At that time she was 68. It's a very young patient. He's now coming in April to the yearly control. So we also after 7 years. However, this old lady developed local regrowth after 2 years, and we operated her after 2 years. So in organ preservation, you have, when you think about, you have local transanal local excision in early, very early tumors, or early tumors, or even after upfront chemoradiation for mostly large tumors to omit a TME surgery. So only very, very shortly, if we compare watch and wait and the local excision after TNT, only very shortly to say that the results are excellent, but however, you have to say you do not have a histology. You have to expect a high rate perhaps of regrowth and related growth, but on the local excision, you do not know if the lymph nodes behind are positive or not. You know, the watch and wait surveillance, especially the very first 3 years, are very important. And the indication for neoadjuvant therapy, if you go for surgery, there is only for the upper third, and for the lower and mid third, you go for the TNT. So except you have MSI high or mismatch, then you go for immunotherapy. Only very briefly, if you compare the TNT, that's the paradigm shift, the control group, the Rapido trial show us the short course radiotherapy, chemotherapy, and then the operation. The disadvantage was of the Rapido therapy that the failure was about in more than 10%, and the Protege study, also the control group, giving the chemotherapy first, and then the radiotherapy, then TME. It is an advantage for neoadjuvant chemotherapy here, followed by chemotherapy in terms of survival, and many institutions doing this. or they're doing the OPRA study. That's the consolations, the induction therapy, comparing the consultation therapy. That means you start with the radiation therapy, or you start with the chemotherapy. So the results are for the consolation therapy are better the TME in terms of the TME-free survival. The OPRA studio showed at first time that it's a boost therapy comparing two groups, and the group B contains 90 gray in 3 fractions, and very briefly only they are doing better in terms of local recurrence and the operation rate, especially when the tumors are small. So I come to the conclusion that therapy for local advanced rectal cancers include a combination of chemo and radiation and then surgery. If cure is achieved, radiation and surgery may impair life. Following chemotherapy and radiation, 30% became candidates, only 30% for non-operative management for watch and wait, but we do still not know which patients go in that way. And the immunotherapy will play a role in the future. Safety, it is safe and feasible to make a watch and wait. The TNT, which I told you now, is in the selective cases, is now the new standards. It's really a paradigm shift, and many patients with profit of this procedure in the non-operative management. What is the current status? It includes the TNT includes major guidelines, NCNC, ESMO, and so on, for large tumors and positive invasion of the mesorectal fascia, improved oncological outcome, and increased the organ preservation. But it's a limitation. There are limitations, and there are open questions. Is there a patient selection? Which stage should we do this procedure? The toxicity, and do we overtreat some patients? Are there different regimes, and there are biological risk factors? And we could publish our paradigm shift in the paper of Jerry Hoch just last year. So, and finally, I would like, as I stated in the beginning, I would like to invite you all to our 14th EFR Congress from September 10 to 12 in Vienna. You are cordially invited. Thank you very much for the invitation.